I hope you're enjoying the class so far. This week, we've got a few different chapters. We're going to start out with chapter 9. This is on airway management. So we're going to go through things like the physiology of the airway, the opening of the airway, obstructed airways, how to deal with that, suctioning, and how to keep an airway open. So starting off with the physiology of the airway is divided into two parts, the upper portion and the lower portion. The upper airway kind of begins at the mouth and nose. The pharynx lies posterior and inferior to the mouth, so just kind of right behind. And then the nasopharynx is the upper portion, oropharynx is the lower portion. So we kind of call the whole area the pharynx, and then we can get more specific by dividing it into those two parts. The laryngopharynx is the lowest portion. The larynx is then the boundary between the upper and lower airways. So kind of looking at a diagram here, I always find it helpful to look at diagrams versus just reading off the slides, right? So looking at this, you can see that we've got our nose, which goes into our nasal cavity. We've got these turbinates here in the nasal cavity that help kind of warm and filter air. And then it goes back into our nasopharynx, which is the very back of our throat. And then you can see mouth here. Obviously, we've got lips, teeth, tongue, all of those fun things. You guys should be familiar with those, hopefully. And then the very back of our mouth, we've got our oropharynx. From there going down, we've got our laryngopharynx. This is where we've got our epiglottis, we've got our vocal cords, and then we've got the division between the trachea, which goes into our lungs, and the esophagus that goes into our stomach. So the epiglottis here, and I think we talk about it a little bit later on in this lecture as well, but this is a really good diagram to describe it. So this epiglottis here is a big kind of flap. It's a big flap. In the resting position, this flap is open. So if we're just hanging out, chilling, watching TV, whatever, it's going to be open in this kind of relaxed position here. When we go to swallow something, that epiglottis folds down and covers the opening to our trachea so that food doesn't go into the trachea, of course. So that being said, when you accidentally, swallowed and you breathe at the same time, right? That weird quirky thing that we do sometimes where you like inhale whatever it is you're drinking or whatever. That's a malfunction with the epiglottis. Either your timing wasn't correct with it, or maybe you do have like an issue with your epiglottis. There are people out there that have epiglottises that are too short, and therefore when it folds over to cover the flap, it doesn't cover the flap, or it doesn't cover the hole all the way, and they have some leakage that happens. There's also people that have issues with their timing of the epiglottis. And then, of course, there's just us being humans and not paying attention to what we're doing, and we get the timing wrong, and we end up inhaling whatever we're drinking, or sometimes even whatever we're eating, right? Now, we're going to talk about choking here in a moment as well, but again, I really like this image. I think it does a good job of showing kind of where the different structures are. So when we go to swallow something, we'll say we're eating, it's the 4th of July this weekend. We'll say we're eating hot dogs, right? Classic hot dogs. We go, we chew, we swallow, but maybe we took a really big bite and it gets stuck in our airway. Now, that's choking, right? You guys are probably familiar with the idea of choking, at least. There's several different places where choking can occur. It can be at the back of the throat here, like on top of the epiglottis. And if it's happening there, patient's not going to be able to breathe, right? Because the trachea is down here. There's people that accidentally inhale things that can then get blocked in the trachea itself, which is the least likely, I would say. And then there's other people that swallow something too big and it gets stuck in their esophagus past the opening of the trachea. So this does happen. It's not as common. The most common one is to be kind of up here at the back of the throat. If it happens, say, down here in the esophagus, because it's past the point of the trachea, the patients are still able to breathe. They're still able to talk, but they're not able to swallow anything else, right? So if they go to take a drink of water, it's going to come right back up. Yeah. All right, hopefully there's no more questions on that. I think I got all of it covered for the most part. This is incredibly important, the structures of the airway and how everything is kind of connected to each other, and the terminology of where everything is located is incredibly important as well. So the lower airway is the trachea that's below the larynx. So if you wanted to feel your larynx, it's kind of where your voice box is, or your Adam's apple. So if you just kind of pull your finger down the center of your throat here or your neck, you should be able to feel where your Adam's apple is at. Everyone has one. Just males tend to be a little bit more prominent, right? You should be able to feel that, and it's right there. That's the larynx, where it separates from upper and lower airways. From there, we go into the main stem bronchi branch that then divides into, or sorry, you've got larynx, trachea, and then your main bronchi that then separate into even more bronchial branches, the secondary branches, and then at the very end of those branches, there are alveoli. So I like to picture it. I'm kind of a weird visual person, right? If you've got a really big apple tree, and there's tons of apples on these apple trees, and they're all in kind of clusters. I have no idea if that's how apples grow, but they're in clusters. We're saying they're in clusters, all right? If you take that whole tree and you flip it upside down, so now the top of the tree is at the bottom and the branches and everything are at the bottom, right? That's kind of how I imagine this right here, right? We've got the main trunk, which is our trachea, that goes up and it divides into these right and left main stem bronchi, those two big branches there, and then it separates off into these little tiny ones here. At the very ends of these little tiny branches, we have our alveoli structures, and that's where the magic happens. Now, a lot of people say that this also looks like the root system of a tree as well. If that's better for you to understand and to be able to visualize how this works, perfect. Because of those air-filled sacs, those alveoli at the very tips of those branches, I like to think of it as an apple tree the other way around. But all of our brains work differently, right? Whatever works for you. Now, fun little trivia here. It's not crazy important for this particular class, but if you do plan to go on into the medical field a little bit further, the carina becomes an important benchmark, and that's kind of right between the split, or where it splits into the left and right main stem bronchi. So that's called the carina here. Again, not incredibly important for this class. You may or may not get a test question on it, or if you go on to take the National Registry, you may get a question on it, but really important when you start getting into airway management at the more advanced levels. So we talked about those little sacs at the end of our bronchioles. These are called alveoli. These are the airway sacs. And like I said before, this is where the magic really happens. This is where we have gas exchange at the cellular level. We're hoping anyways, right? So when we breathe in, that was a really short breath, but when we take a deep breath in, the air goes through our upper and lower airways, down through the left and right bronchi, into those little bronchi that branch out and touch the alveoli. So that's where we're at. Here we're in the alveoli, microscopic level, right? When we breathe in air, if we're just sitting at a normal altitude per se, actually any altitude, we're breathing in about 21% oxygen. So when we breathe in, we're breathing in a lot of stuff, right? A lot of stuff makes up the composition of air, but we're looking at that oxygen specifically. So when we breathe in oxygen, the oxygen come into these alveoli, and over these alveoli, there's a spider web of capillaries, and those capillaries are in charge of allowing oxygen molecules to diffuse into the bloodstream. And while that's diffusing in, we have carbon dioxide that's diffusing out back into the alveoli, so that when we exhale, we are exhaling carbon dioxide, the waste products of our system. I know I went through that kind of fast, but we will touch on that quite a lot today. So airway physiology, pediatric airways, we're not all created equal. Adults and children are different, especially when we're looking at the airway. Yes, all of the components are the same. We all have tongues, we all have tracheas, etc. But how those structures are in the how they're positioned, I should say, and the difficulties that we have with one airway over the other are different, right? So the mouth and nose are smaller in children, more easily obstructed, right? So something like a cold can be a little bit harder on kids because they're more easily obstructed. Their tongue is also proportionately larger. If you've ever looked at a child, they have really large heads in proportionate to the rest of their body, and their tongues are even larger in proportionate. Newborns and infants tend to be nose breathers. So again, if they get a really bad stuffy nose, that can be a real issue for them, right? Trachea is also softer, it's more flexible, and it's narrow, so that can be more easily obstructed, especially when you get, a really excited kid on the 4th of July, mowing down on a hot dog, and they take too big of a bite and don't chew properly, and they, swallow this massive, wad of food. It can get stuck a lot easier. Their chest wall is also a bit softer, and their breathing is more dependent on their diaphragm. So we often say that kids are belly breathers. When they breathe in, their chest wall doesn't expand per se as much. It's not as noticeable. It's their abdomen that kind of moves. So here you can see kind of a diagram. The other thing is with the smaller the child is, the bigger their head is in proportionate to their body. So you can see here, this kid is laying flat. His airway is fairly open. But if that head were to be any bigger, it would start kind of moving that chin down to his chest and closing off their airway. So oftentimes when we are dealing with kids and having breathing problems, we want to elevate their shoulders to make sure that that airway is nice and straight. This is a fun little thing. I've got a very young nephew. He's he's about to turn 5 months old. And it's kind of fun to do some little medical experiments on him, right? So laying him flat and seeing, when he lays flat, his chin almost immediately goes down to his chest because of how big his head is in comparison. It's also kind of fun. Pediatrics, infants especially, have a whole bunch of different reflexes that they're born with. It's fun to see if he still has those too. So airway physiology, a variety of obstructions interfere with airflow. Foreign bodies, food, small toys, pretty much anything that goes into the mouth could potentially obstruct the airway. Other things like liquids, including blood and vomit, liquids that we produce on our own, can also obstruct the airway. Loss of muscle tone can obstruct the airway as well. This is something that, yes, it does certainly happen with altered mental status. But if you know anybody that snores, which usually most people know several, but if you know anybody that snores, the loss of muscle tone, everything relaxing, letting that tongue fall back into their throat is what causes that snoring. So obstructions can be acute or chronic. There's different chronic conditions that can cause airway obstruction or partial airway obstruction. Or it can be acute. It can be, that kid swallowing a big wad of food, right, and it getting stuck. The airway must initially be evaluated and monitored for patency and then continued over time. So when we go back to our assessment that we were talking about, where we've got our ABCs, our airway, breathing, circulation, when we're looking at our airway, we want to know, is it open? Is it patent, open? And is it going to stay open, right? So that's where we're at kind of in that assessment. Is it open? Is it going to stay open? Severe allergic reaction, otherwise known as anaphylaxis, can cause rapid airway tissue swelling, which is an obstruction, right? That's bad. Burns, blunt force trauma, and certain infections can also cause issues around that glottic opening, and we'll go more in depth with that in later chapters as well. Smooth muscle constriction of the lower airways changes the airway diameter and creates resistance. So really long, fancy way of saying, something like asthma. When we have partially obstructed airways, whether it's upper airway, lower airway, etc., our airway produces different sounds. So snoring would be the one that we're probably all pretty familiar with. snoring, when we talk about snoring medically versus snoring during sleep, there is a few differences, right? Snoring during sleep is more of a chronic issue. It can be caused by quite a lot of different things. And a lot of the time, it's not detrimental to the patient. Now, that being said, we could talk for hours about how snoring can harm the body and all sorts of stuff. Focusing in on it from an emergency medical standpoint, it is slightly different. So it is indicative of diminished muscle tone. So oftentimes we're seeing this in patients that are incredibly intoxicated or have taken a lot of drugs. So think like your heroin overdoses or your, like I said, alcohol intoxication. You get a lot of snoring from that. But we also have things like stridor, hoarseness, and gurgling. Stridor is a very high-pitched whistling sound that happens when there's a narrowing of the upper airway passages, specifically as an upper airway problem. So think of either somebody that's got like a really tight airway because it's swollen, they'll sometimes have stridor, or if they swallow something that is causing a partial airway obstruction and there's just a little bit of pathway for air to get through, it'll cause kind of this whistling noise. Hoarseness is a raspy change in voice, and it's indicative of swelling around those vocal cords. And then gurgling is a bubbling sound indicative of vomit or other secretions within that airway. So gurgling, we want to suction that out, right? That should be our sign to suction. Now, these can be really difficult to understand. I do strongly recommend going on YouTube and just looking up airway obstruction sounds or airway obstruction sounds. There's a lot of really good videos out there. So when we're looking at the airway, is it open? Will it stay open? If the patient's able to speak, immediately indicator that the airway is open, right? If they're able to speak, they're moving air. Now, how they speak can be indicative of to whether or not that airway will stay open. So if you've got a patient that's speaking in one word in between every breath, right, or only a couple words in between every breath, that's indicative that they do in fact have a breathing issue happening, and the likelihood of that airway closing is there, right? It's higher. But if it's somebody like, say, me sitting here right now where I'm talking in complete sentences, I'm rambling on about airway stuff, you can just about guarantee that my airway is in fact open and it's going to stay open for the duration of the call as of right now, right? But if I'm huffing and puffing and trying to breathe in between each word, that's a sign that, hey, there's something going on, right? Stridor can also be present on that inhalation and exhalation or both, and that, of course, is a very ominous sign. If you do have a partial airway obstruction, the likelihood of that turning into a complete airway obstruction is pretty high. So we want to make sure that we're staying in that ABC area and fixing the problems. So one of the first things that we should do when we come across a patient that is in fact having some difficulty breathing, we want to sit them up right away, and it helps ease their breathing a bit. So when we're going to assess the airway, we want to make sure the airway will stay open. Now, I would say I don't want to say it's easy to tell if the airway is going to stay open or not, but when you get a patient, say you're looking at me, I've got a broken wrist, I called 911, you're here, it's fairly easy to make that assumption that their airway's good for right now, right? But if you have somebody that does have, the difficulty breathing, you really want to go back and ensure that that airway is staying open. If there's any sort of changes to the mental status of the patient, you want to go back and make sure that that airway is still open. Because without an airway, we won't have a patient that's alive for very long, right? So it's a really important thing that we're assessing that airway. The ability to maintain an airway can change over time, so that mental status, and there is no guarantee that an airway will remain open. So the change in mental status is a really big one that we look at. Even patients that initially are okay, we're thinking that, hey, our airway is good to go. If they do have a change in that mental status, we really need to be going back to our assessment and reassessing that airway right away. So some signs of inadequate breathing would be no breathing, no airway movement at all, evidence that there might be something obstructing the airway, no air felt or heard at the mouth or nose, inability to speak, unusual hoarseness, absent, minimal, or uneven chest rise and fall. Breathing movement is limited to the abdomen. This is adults specifically. Remember, our pediatric patients tend to be those belly breathers. So if it's adults that are limited to the abdomen, we've got some issues. Diminished or absent breath sounds, abnormal noises like wheezing, crowing, etc. that we talked about. In children, retractions above the clavicles and between the ribs are indicative of this as well. So this can happen in adults too. It's a little bit scarier in kids. But when you're trying really hard to breathe, you start using those accessory muscles, so you get retraction. So it's some muscle movement in between the clavicles and in between those ribs. Another really easy thing to YouTube, you can see a whole bunch of videos of kids with retractions. So opening the airway. How do we open the airway? Well, airway problems must be dealt with immediately, right? Once we come across the problem in our ABCs, we want to fix it before we move on. We're going to open and maintain the airway with a patient who cannot do it for themselves. So to do that, we have two different methods. We can use the head tilt chin lift or the jaw thrust maneuver to open the airway. If you suspect any spinal trauma, we want to make sure that we're protecting the head and neck while we are opening the airway. So that's where we do the jaw thrust maneuver. It keeps the head in place and just lifts the jaw, which indirectly lifts the tongue off the back of the throat. In any unconscious patients, we want to watch for that indication of neck and spinal injuries. If we don't know what happened with the patient, we're going to assume that they do have a head or neck injury and be protective of that, right? We're going to take spinal precautions. Oh, excuse me. Some patients have open airways, but they're threatened. So conscious patients, should be helped into a comfortable position. Typically, that's going to be sitting upright. And unconscious patients should be placed in a head elevated sniffing position. So to do that, we elevate the head of the cot at least 15 degrees. For these patients, we're looking more at like a 45-degree angle. And we like to raise their head slightly. So if you've got a pillow behind them or something a little bit harder, like a roll of towels or blanket that you folded, something like that, to elevate their head slightly into that sniffing position. The slight elevation and anterior positioning of the head aligns the airway structures for that improved patency. So if you guys all kind of do this with me, it looks silly, I will say, it looks silly, but if you kind of, sit up nice and straight and pull your chin in towards your neck. So you're kind of pushing back and pulling your chin in. And then try and take a deep breath. It is probably a little bit difficult for you to do, right? Not impossible by any means, but probably a little bit difficult. And if you're having to do that for an extended period of time, you're going to get a little short of breath, right? Now try and extending your chin out, right? Pushing it out a little bit, sitting up nice and straight, and then taking a deep breath. You're probably able to get a lot more air in that sniffing position with your chin extended than with it being kind of back towards your throat. That's the whole point of the sniffing position, is to be able to get more air into the airways. So optimal positioning is achieved when the patient's ear is at the same level of the suprasternal notch. So you want it kind of, you want your ear kind of located right with that sternal notch. All right, so like straight down. So just elevating your head slightly is the correct positioning. Obviously, if they've got some spinal injury, it's contraindicated. We don't want to be moving their head too much, right? So we need to manually maneuver their airway. This is with patients that are unresponsive or semi-conscious. So if you've got somebody that's got, major head trauma, or maybe they are incredibly intoxicated and they've got snoring sounds going on. This is for them, right? We need to manually move the airway. So to do that, if they don't have any head or neck trauma, no spinal trauma, we're going to do the head tilt chin lift maneuver. And to do that, it's hard to do on like a person. This is definitely a skill that we'll talk about in our skills days, like in our labs. But you have everything in kind of a neutral position, but you push back on the forehead so that their head is tilted back, and then you lift up their chin. You kind of push it forward towards the sky, right? That's the head tilt chin lift, and that indirectly lifts the tongue off the back of the throat. The jaw thrust maneuver is a little bit different. So this one is, this is the head tilt chin lift here. So you can see we're pushing kind of the head back and pulling that chin up, indirectly lifting the tongue off the back of the throat. This is the jaw thrust maneuver. So we're kind of putting our fingers underneath their jaw and pushing it forward and up, but we're not moving the head or neck at all. And again, this indirectly lifts the tongue off the back of the throat. In these instances, it is a little painful for the patient. Like they might get some bruising where your fingers were at after the call. Not something that we're incredibly worried about during the call, but that's why one is preferred over the other. So if you've got a patient that doesn't have any sort of head, neck, spinal trauma at all, the head tilt chin lift is a little bit nicer on them, and both of them are incredibly effective. Now, note, you might be already doing this on yourself, but when your musculature around your jaw is engaged, which it is if you're awake, it's not as easy to do, and it can certainly hurt if you do it to the point of it being a little forceful. So be careful if you are doing this, and I don't want any of you to actually be doing this on your patients in class. All right, if they're mannequins, go for it. But if they're, alive, real patients, don't do it. So moving on to obstructed airways, if an open airway remains obstructive, we're going to consider the possibility of a foreign body obstruction. So if we've got, say, a patient that's unresponsive, we open the airway, we're not able to get air to pass through the airway, we're going to consider that it is a foreign body obstruction, and then we can attempt to remove that obstruction. And we'll go through that in class as well. Choking is classified as severe or non-severe. So in severe choking, the trachea is completely blocked and no air is moving. In a non-severe choking, it's only partially blocked. So there is some airway exchange that is happening. Partially blocked airways can turn into completely blocked airways if it's not corrected. So both are incredibly dangerous. The severe one is more life-threatening than the not severe. So apparently we're not supposed to call it the Heimlich maneuver anymore. Heimlich's family got upset or something like that. So don't tell on me, because I'm just going to probably revert back to calling it the Heimlich maneuver. But we're not supposed to technically teach it that way. But that's what we're going to do for patients that are conscious. If they're conscious, they don't have any airway movement, they've got that severe choking that's happening, we're going to stand or kneel behind the patient, place a fist over the navel, grasp it with the other fist, and then kind of move up and quick with forceful thrusts, and then repeat until the obstruction clears or the patient goes unconscious. In infants, we're going to treat it with back slaps and chest thrusts. This is something that will be covered in your CPR class. We'll actually go through the motions of doing this in your CPR class. If you can't wrap both arms around the adult patient to deliver thrusts, we're going to position the hands over the sternum. And if the patient is unconscious or becomes unconscious, we're going to start CPR. So again, all of that will be included in your BLS CPR class that you're going to do. Airway adjuncts. So the first thing we want to do with our patients that have obstructed airways is to manually open that airway, right? The head tilt chin lift or the jaw thrust maneuver. But that doesn't work 100% of the time, right? Sometimes, it'll work initially and then, your hands get tired, so you're not doing the movement as effectively, or the patient is getting worse, so there's more secretions that are building up, all of these different factors, right? So what we like to do is we use airway adjuncts in conjunction with the positioning of the airway. So an adjunct, we've got two that we can use as EMRs, or actually all the way up to paramedics. There's two that we use: the oropharyngeal airway, or the OPA, and the nasopharyngeal airway, or the NPA. Now, for whatever reason, my students always seem to have a hard time remembering which one goes where. Now, not only do these two look incredibly different from each other, it also is in the name. So if I were to say to you, which one of these two are we going to put in the mouth? Hopefully, you would say the oropharyngeal airway. Now, if I were to say which one of these goes in the nose, hopefully you would say the nasopharyngeal airway, right? Now, I do understand that it's hard to remember nasopharyngeal or oropharyngeal. It's a weird word that we don't use very often, right? OPA is completely acceptable in this class, and so is NPA. So if you can't remember nasopharyngeal, NPA is completely acceptable. The main function of these devices is to keep the tongue off of the back of the airway when that muscle tone is diminished, right? So they both go into the airway to indirectly, or actually directly, lift the tongue off the back of the airway. The contraindications for OPA usage is that the patient has a gag reflex. So if you take a person that is severely intoxicated, usually they still have a gag reflex, all right? So we can't use OPAs. We can, however, use an NPA in that situation. All of us right now, we could have an NPA placed in our nose. Granted, we'd all probably be very unhappy about it, but we certainly could all take an NPA. We could not take an OPA. Our gag reflex would be stimulated and we would all be vomiting. So we want to make sure that we're still using that airway techniques to manually maneuver the airway, the jaw thrust maneuver, the head tilt chin lift, and then use the adjunct. When inserting the airway, we want to make sure that we're not pushing the patient's tongue backwards. The idea is that we want to get the OPA behind the tongue, right? And we should probably be suctioning a little bit prior to the insertion of the airway. If we start to insert the airway and the patient begins to gag, we want to stop what we're doing, maintain that head position. We'll probably need to suction a little bit. And yeah, that's pretty much it. Probably go to or consider doing the NPA. So OPA is a curved plastic device. It has a flange on one side that will rest kind of on the lips. And it helps to move that tongue forward. OPAs come in standard sizes, anywhere from teeny tiny neonate to huge person, right? And I'm not talking huge like weight-wise, I'm talking huge like airway size. It needs to be the correct size to work appropriately. So again, the idea is that this curve is kind of going around the tongue and indirectly lifting it up off the back of the throat. And then this flange kind of sits on those lips. We'll work on insertion of this on our skills day as well. So to determine the appropriate size for an OPA, we want to go from the tragus, or the kind of corner of the ear here, all the way up to the lips, right? Oropharyngeal airway, it's going to go into the mouth. So we measure from the mouth to the ear, right? When we go for insertion, this is how it will look when it sits into the like airway. When it is inserted, it'll look like that. This one is too short, right? Or actually, excuse me, they're doing a different technique here. They're going from the middle of the mouth to the angle of the jaw. I prefer this way. but this one is actually kind of backwards as to compared to this one, which is how it would actually sit in the patient's airway. We actually start inserting this upside down, so we'll insert it like this and then twist as we go down into the patient's throat. And again, that's something that we'll do during class. So it looks like this when you start to insert it, just to get behind the tongue so we're not pushing it back. And then we twist 180 degrees down into the patient's mouth, and it will kind of rest there. Now moving on to the NPA. So this is used when the patient has an intact gag reflex or the patient's teeth are clenched or any sort of oral injuries, broken teeth, things like that that we don't want to disturb or make worse. So we'll use the NPA. It goes into the nose. Now, I know there's some discrepancies out there currently. Book standard, National Registry standard is currently that it is contraindicated with basilar skull fractures, nosebleed, or any sort of nasal trauma. Now, the reason I say that a little odd-like is because there is a lot of studies being done that shows that the force to be able to get the NPA through a basal skull fracture and into the brain, which is the major concern there, the force needed is way more than is capable with an NPA, right? It's a soft, flexible tube. It's not likely that you would go into the patient's brain with it, even with a basilar skull fracture. So you may come across that depending on which services you work at. They may start to tell you things like that, which is fine, right? That is the up and coming information that is happening right now in the medical field. That being said, our textbooks and the National Registry are a little behind, right? They can't always change things right now. So National Registry, this class, this textbook, all of it is saying it is contraindicated in basilar skull fractures or any sort of facial trauma. Now, like I said, it is soft and flexible, and of course, it will be going into the nose rather than the mouth. So to measure the correct size, we're going to the corner of the ear to the nose. This one goes in the nose, so we're going to measure corner of the ear to the nose. OPA is corner of the ear to the mouth. Right? Now, again, one of those real life versus book things. I'm okay if you do it either way in class. Lubrication. Now, most people, if they're in need of this airway being inserted, they have enough lubrication naturally that they don't need any extra. It'll make it way too slippery and it'll literally just kind of pop out of their nose if they start breathing and it's got way too much lubrication. All right. Book says put lubrication on it before you insert it. If you were doing this on just a regular person in class, which we're not going to do, but if you were doing it on just a regular person that wasn't in need of it, lubrication would be necessary to get it to pass appropriately. So when we do this, we want to kind of make our patient into a pig a little bit, right? We're going to do a pig nose on our patient. And we want to make sure that the bevel on this device, you can see it's kind of beveled here at the end. We want to make sure that that bevel is towards the septum of the nose or towards the center of the nose, and then slide it on in. Real life wise, this does go in fairly easily. There shouldn't be really any resistance to it. If there is, you can try just a little bit of pressure, but if it's not going in, and it'll be fairly obvious, if it's not going in, don't force it, right? Most people naturally have one nair, one nose hole, nair, that is bigger than the other. We do like to go in the one that's bigger, but that means that that bevel is not going to be in the or towards the septum with this natural curvature. Now we can put it on the other side. We just have to twist it just like we would with the OPA. Supraglottic airways. So supraglottic airways are going to go a little bit farther in. So the OPA and the NPA just go at just right behind the tongue, essentially. Supraglottic airways go a little bit deeper. They specifically go into the esophagus and isolate the trachea. So I'm just pulling up a picture here. This device is called the iGel. This is the one that's most popular right now. And you can see it just inserts into the airway past the tongue. It goes down into the esophagus, and the whole of the iGel isolates that trachea, and you're able to ventilate the patient through this device. All right. This does come in many shapes and sizes, and it is off of weight of the patient in kilograms. So yes, you will need to know how to convert pounds into kilograms for this class. Now, I have put these in before, and they do work very well. They go in very easily with the patient. The iGel has a gel-filled cuff at the tip of the device that is heat reactive. So when you put it into a patient, it molds to the patient's anatomy, and you should get a good seal. The biggest issue I found with that is that a lot of our patients are not warm, right? Most of the time they're kind of at the point of being, gone. So the next one we have is a King Tube. This one is still out there. It's not as popular. You do need to blow up these little cuffs here. So there's a little bit more steps with the insertion of the device. There are multiple sizes. This one is based off of height, not off of weight. But you can see, same idea. It goes into the glottic opening or down into the esophagus, isolates the trachea, and you ventilate, obviously, at the tip here. So that's the King Tube. Combi tube is the one that you probably won't see. I won't say that you'll never see it. I know there are some services out there that do still use it. There is quite a lot to this device. One, it doesn't come in pediatric sizes, as far as I know anyways. So it's kind of a one size fits most type of situation. There are 2 balloons on this device. On the King Tube, there's one inflation cuff, so one little cuff here that you inflate, and it inflates both of the balloons. This one has 2 balloons and 2 cuffs, so there's yet another extra step that you need to do. The idea, and I'll go through this in class, but the idea is that one of these openings up at the top will go into the trachea, the other one will go into the esophagus, so it makes it a little bit easier for suctioning. Rescue. I think that's what it's called. Maybe not. This one, AirQ. AirQ is what it's called. So this is the newest one. I don't have this device in our arsenal of equipment. It's that new that we just haven't gotten it yet. Very, very similar to the iGel. It does, however, have a cuff that you need to inflate. Its shape, how it goes in, very similar to that iGel. Again, going into the esophagus, isolating the trachea. You inflate the cuff initially, and then with each ventilation, there's a little bit of air that goes into that cuff to make sure that you're getting a really good airway seal. So this kind of helps with the issues that the iGel has had with getting a good seal on that airway. So again, this comes in all shapes here. I personally have never used this device. Again, the service that I work for does not currently have these, and they're new enough that, I've played with one once, but I've never actually gotten to insert it into a patient. I'm trying to remember. I'm not sure if this is weight-based or height-based. I'm thinking it's weight-based. Can't really see on the device, so I won't say anything definitive. I will try and get one of these for our classes. I do know one of our TAs does work for a service that has these, so we'll try and get one for the class. But those are all the supraglottic devices that you can use. Anytime that we're testing on them in class or doing any sort of skills with them, the very first time I introduce these, I want you to try all of them at least once just to get the feel for the differences. But when we're testing, you can go with whatever one you're most comfortable with. So for instance, if you're going to be working for a service that has the eye gel, you can just stick with the eye gel. But I want you to get hands-on with each of them. I'm a big believer in the idea that even though we start at one service, we may not be there for the entirety of our career, or they might change supplies and equipment, things like that. So you might as well get hands-on with everything, right? No harm in that. Let me get my clicker working here again. Went through that. Suctioning. So we suction quite a lot in EMS, especially with our patients that are unresponsive. We can suction things usually like liquids, specific, so blood, spit. We can suction vomit. Just be aware that the suction tip, if it's not big enough, can get clogged and blocked when you start to suction vomit. So just kind of keep that in the back of your mind. That doesn't work super well for like really chunky vomit. When we can, we always like to use gravity when we're assisting our patients with clearing their airway. So we do like to lay them on their side. For a few different reasons, we always want to lay them on their left side. It doesn't have to be, but there's a few circulatory things that that are better if the patient's laying on their left side. So we try and do left side, but let gravity kind of help get everything out of their mouth. Several different types of suctioning devices. You have portable suctions out there, so you take them with you into each call. You've got manual suction devices, so those are ones that you're like using like a hand pump to help clear. I don't see those too often, but if you're working for a just responding first responder service, you might run into those. And then we have mounted suction units within the vehicles themselves that have like different components that connect into the truck. All right. Each suction unit should be relatively similar. They should all have a suction source, a collecting container, some sort of tubing, and then a suction tip or a catheter. So this one is one that's mounted to the truck. So you can see it goes into and connects to this little piece here. You've got your tubing. This is a Yankauer tip that's on here. That one is a very common tip, suction tip. Just know your equipment and how it works, all right? That's the big thing with this. Everybody's got something that's a little bit different, so know your equipment, all right? The larger the bore is on the suction, the bigger chunks you can suction. All right. So if you are suctioning a patient that, just had a vegetable medley soup and there's chunks of carrots and celery and all those types of things, having a bigger diameter is really nice. Our soft suction, so we talked about the rigid suction, that's the Yankauer tip. Our soft suction comes in French. I don't know the history behind that and why some of ours are measured in French. Some of our equipment is measured in French, but it's a unit of measurement. The larger the number, the smaller the diameter. So it kind of goes backwards from what you would think. So if I've got a 22 French versus a 18 French, the 18 is going to be a bigger diameter. The 22 is going to be small. So soft suction can be really helpful when suctioning pediatric patients. Also, if we're going to be suctioning down one of those supraglottic tubes, we're going to use the soft suction. The collection container should be non-breakable. Typically, they come in plastic. They used to use glass, so for obvious reasons, it's now plastic. And there You may have the ability to have a water container next to you to help clear partially blocked tubing. That being said, having excess water on our ambulance is a luxury that most ambulances do not have. So when we're suctioning pediatric patients, we need to be very careful that we're not stimulating their vagus nerve. The vagus nerve kind of runs along the back of the throat. If it's stimulated, they have a decrease in heart rate and a decrease in blood pressure. This is something that actually happens quite a lot with elderly patients, or any patient that's bearing down or trying to void their bowels of anything really, but if they're bearing down quite a lot, this vagal stimulation can happen. It's the same thing, just happening with suctioning. So we just need to be really careful with that. We don't want to go back too far or suction too long with these kids. Bulb syringes are super common with infants. We do still use those. They work very well, as long as it's a small something that needs to be suctioned, right? Otherwise, we're going in with McGill forceps, which again, we'll talk about in class. We don't want to suction any longer than 10 seconds. Most of the time when we suction, we're going to go in and then suction on our way out. There are some other devices out there, some different styled tips that will allow you to suction on the way in and on the way out. It just, again, depends on your equipment. So this tip here is the Yankauer tip. Decanter is the other one. Just pulling up a picture of this here. This is the other one. It's a slightly different tip shape. So you can see the Yankauer here, decanter here. The bore on it is bigger, and it does suction continuously, whereas the Yankauer, so you can see the difference in the tips here. These are both, or these, yeah, all three of these, I believe, are Yankauer tips. So you can see the bore is a lot smaller. There is no hole on them. Yankauers have a small hole that you have to cover to create suction, whereas the decanter is one piece, so you don't need to make sure that your finger is placed anywhere specific, whatever is comfortable for you. When we're dealing with our airway, the needs of the airway may exceed the capabilities of EMTs, EMRs, even advanced EMTs. So if we do have a patient that needs definitive airway treatment, like an ET tube, we need to call in our ALS providers or the paramedic providers if we have the ability to do so. So our ET tube or endotracheal tube is a little bit different. This is the one that you probably have seen in things like Grey's Anatomy. For those of you that maybe are a little bit older, ER was a big popular one. Strongly recommend it. Or The Pit, I guess that's a new one. This is typically what they're using in those situations. So this is a definitive airway. So remember how we said that the supraglottic airways go into the esophagus and isolate the trachea. These go into the trachea, so they can come cuffed or not cuffed. So this one up here is not cuffed. Cuffed just means it has this little balloon. So you can see in this image here, it goes through the vocal cords and into the trachea. So it's considered the definitive airway. And only paramedics can do this in the state of Wisconsin. So we need to make sure that we call them if we need something like this. So biggest difference in why we would need this over just a supraglottic airway. If the patient is going to have it placed for an extended period of time, this is preferable. It's a lot easier on their body. The supraglottic airway does introduce a little bit of like air into the stomach, and eventually that air has to come out, and usually it comes back out the airway, which can cause its own set of problems. So we like to do ET tubes if it's going to be in the patient for an extended period of time. Supraglottic devices work, but typically they'll get switched out for an ET tube after a while. Moving on to some special considerations. Facial injuries. Bleeding with facial injuries requires constant suctioning. Our faces, our heads are very vascular, so they bleed a lot. So we need to make sure that we are suctioning quite a bit. Airway adjuncts may be needed for those situations, and then suction units, of course, are not adequate for removing solid objects. So for that, we would get something called a laryngoscope and a miguel forceps out to actually remove the obstruction. Dental appliances, if it fits appropriately and it's in place, we just leave it in place. So if the patient has dentures in, but they're securely fastened to their mouth, we just leave them in. If you have a person that has ill-fitting dentures, or it's just kind of flopping around in their mouth, we want to take those out. Same thing with partials. Full denture sets is like a full set of teeth. A partial would just be maybe 2 or 3 teeth. If it becomes dislodged, we're just going to take it out. Just make sure that you do, in fact, keep those with the patient. Those are incredibly expensive appliances, so we want to make sure that the patient keeps them, right? And that was the end of this lecture. It's kind of a long one, but important chapter. All right, let me stop my lecture here. There's some other breathing sounds that we can get from nose and mouth, and we should be free of sounds associating with obstruction. So I know I said that really weird. I kind of stumbled over my words, but before we have those sounds of obstruction, this is sounds of, like, there's some other breathing